Management of adhesions in spine surgery. Good afternoon. My name's Frederick Moore. I'm an orthopedic spine surgeon out of Jacksonville. I'm a community spine surgeon working at a busy private practice. And I do chiefly minimally invasive spine surgery. I do, like any community surgeon, a lot of laminectomies, a lot of microdiscectomies. When it comes to fusion, one of my big workhorse techniques is minimally invasive Tlift. So I do that through a tubular retractor. And of course, what all these procedures have in common is they take us right by nerve roots, whether it's the dural sac, the traversing nerve root, the exiting nerve root. I'm there all the time. And of course, for me, epidural adhesions have a particular relevance, whether it's dealing with poor patient outcomes as a result of that, or making my revision cases that much more technically demanding. And so today we're going to talk about the pathogenesis of epidural adhesions, as well as with a particular emphasis on how Amnion can not only help or improve patient outcomes, but also make our revision cases technically easier. A couple of disclosures before we go any further. I am a consultant for Barricade, as well as Organogenesis and Precision Spine. Our learning objectives today will be to examine the cause and impact of spinal adhesions, to explore current treatment options, as well as review case studies using amniotic-derived tissues to help prevent adhesion formation. We're going to start with a case. And this is a case that one of the first cases I did when I came down to Jacksonville, and I was rather new to the area and had not been able to get Amnion approved at my hospital. And so this case, I did not use Amnion material, but this was a 60-year-old female who'd come from an outside facility for a second opinion. She'd had an L5-S1 microdiscectomy and had initially done okay, but then experienced a recurrence of radicular symptoms at about 3 months. These were symptoms straight down the back of her leg, a classic S1 radiculopathy, and was very disabled by it, could not work. I initially saw her for a second opinion, ordered an MRI with contrast. This is a gold standard for looking at scarring around nerve roots. Herniated discs generally have a fixed negative charge, so they're not going to enhance with contrast like the surrounding vascular scar tissue is going to. And so this MRI identified quite a bit of epidural scarring around the left S1 nerve root. And so my options at that time were either a revision decompression or just taking her right to a fusion. Interestingly, our community is split in this situation regarding strategies for making this better. About right down the middle, half of us will opt for fusion, half of us will opt for revision decompression. Oftentimes, my choice is really individualized and tailored to what I see with the patient and what their real symptoms are, whether or not I perceive any instability. And also, interestingly, if you look at surgeons across the board, surgeons who've been in practice longer tend to skew towards revision decompression. Newer surgeons or younger surgeons tend to opt for fusion more commonly. I still don't know that we've solved the answer conclusively. Either way, I elected revision decompression. I felt that I could go down, lyse the scar locally in the area, remove any residual discs that I saw in and around the nerve root. I did this, took me about an hour to do. I did it through a tubular retractor. The patient had early improvement after revision. Notably, I did not place an amniotic patch around the nerve root like I typically do. And of course, she recurred again. She scarred down again, and at about the 6-week mark, developed recurrent radicular symptoms. And at this point, we were at another crossroads. The question is, do I take her back for a fusion of L5-S1, or do we consider a stimulator trial, which can be beneficial in patients with this chronic radicular pain? And so that sets the stage for the relevance of epidural adhesions. We do over 200,000 lumbar spine surgeries a year. And depending on where you read, 13 to 61% of those patients end up with failed back surgery syndrome, meaning they have persistent or recurrent back or leg symptoms after a well-executed surgery. And this can be due for a lot of reasons. You could have performed an inadequate decompression. You didn't get enough disc out. Or the patient could have created new disc, herniated. We know the reherniation rate for a microdiscectomy is about 18%. And so you will see patients recur as a result of that. There may have been unrecognized instability, or it could have been iatrogenic. Maybe there was too much of the facet removed. And then also you go after the wrong pain generator. Maybe this was SI joint pain, or maybe this was, the adjacent level. Sometimes it can be difficult to distinguish those pain generators, which is why you have to be meticulous with your indications. And then, of course, pseudoarthrosis and epidural adhesions. Epidural adhesions in the spine are estimated to be about 40% of failed back surgery syndrome. Either way, epidural adhesions are inevitable in surgery. It's a consequence of creating intraspinal hemorrhage, which is essentially work inside the spinal canal. So a little bit about what epidural adhesions actually are. Essentially what is happening is underneath the ligamentum flavum, you've got a layer of epidural fat and then the dural sac. So what's happening is that epidural fat is becoming scar. That's collagen scar. This results in extradural compression. It results in tethering of the nerve roots, which can compromise your vascular supply. It can impede axoplasmic flow. And we know that although an MRI with contrast is a gold standard to assess scarring, we also know that studies have been done at looking at MRI without contrast. And MRI without contrast, if you look at the morphology of the environment locally there, you can oftentimes distinguish scar from disc and nerve, of course. Importantly, imaging doesn't correlate with symptoms, meaning you can have dense scar. However, for whatever reason, you don't have symptoms. So that makes our, diagnostics a little more difficult. What we do know is epidural adhesions are a primary cause for failed back surgery syndrome, and it most certainly increases the rate of complications in revision surgery. And given that revision surgery is 8 to 45% in lumbar spine, we are going to confront epidural adhesions again and again. It's not so much that surgeons manage epidural adhesions, it's probably more so that epidural adhesions manage surgeons. So the pathophysiology of epidural adhesions begins with intraspinal hemorrhage. And from a bird's eye view, on the right, we have the phases of healing. And so essentially what we see is the arc of all of this following, phase 1, phase 2, and ultimately remodeling months to years down the road in phase 3. It begins with intraspinal hemorrhage, which is basically work inside the spinal canal. This ultimately results in a chemokine-mediated fibroblast migration. In turn, these fibroblasts become myofibroblasts powered by interleukins and growth factors. They subsequently, in that environment, will stimulate angiogenesis, which forms granulation tissue. And that granulation tissue will eventually become dense with collagen, and that will become your scar. This scarring results in traction on nerve roots. It obliterates your surgical planes. And as mentioned earlier, it impairs axoplasmic transport, which is the movement of lipids from the neuronal cell body, as well as other proteins. We're going to restrict our arterial supply and our venous return. And so all of those things ultimately result in increased levels of back pain, poor clinical outcomes, increased radicular symptoms. So significance of this, of course, recurrent radicular symptoms, as in case one, continued low back pain, which we sometimes cannot distinguish from adjacent segment pain, or pain from, the quote unquote instrumentation. It just makes the picture muddier for many patients who have outcomes that are perhaps disappointing. Another thing that's very obvious and intuitive is that when we do need to go back and look at patients who've, for whatever reason, had a poor outcome and we need to revise something, or even lyse the adhesions, our rate of dural tears increases from 1% to 16%. So this is a significant nuisance for spine surgeons. There was a study done by Ross and colleagues that estimated that patients with increased scar tissue were 3 times more likely to have radicular symptoms. This was done on a series of microdiscectomy patients who were followed out to 6 months. And at the end of 6 months, were assessed with ODI scores as well as the SF-12 questionnaire. And were also taken for an MRI with contrast. What was found is that there was a correlation between greater epidural scarring and the rate of continued radicular symptoms. So there was certainly a correlation there, and this was statistically significant. So epidural adhesions and revision surgery, whether you look at the literature or whether I reference my own practice, there are times where epidural adhesions are particularly problematic. MIS Tlift being one of the workhorse surgeries in my practice, I perform probably somewhere between 150 and 200 a year. There's always a few that I am taking back for one reason or another, whether it's pseudoarthrosis, with or without a retropulsed cage, more decompression needs to be done. If you do that number of Tlift, you are going to be bringing some patients back. It's inevitable. And because the working channel of the MIS Tlift is Camden's triangle, this is an area that is lateral to the traversing nerve root, inferior to the exiting nerve root, and under the superior articular process, which is typically removed on the approach. This area completely fills with scar tissue. And when you go back, it is all of these areas are quite adherent. And so there is a significant technical challenge to try to get to where you need to get to when all of your planes are obliterated. And so you'll dissect carefully through scar, and the next thing you know, your instruments will be through the dural sac if you're not absolutely meticulous. The same goes with recurrent disc herniation. Although the facet complex is typically preserved in that procedure, you will find yourself, if you are in that situation, digging through obliterated tissue planes, trying to perform more decompression or remove more tissue. And at times you will have to convert some of these recurrent disc herniations to fusions, and so you'll be performing that through that region. So when we look at epidural adhesions, if we see a lot of different options for management. And so what that should tell people in general is that if we have many, many options for management, we don't have one good option. And so there have been many techniques described for adhesiolysis. One of the classic ones came out of Texas Tech in the 1980s, and this was essentially injecting a hypertonic saline at high pressure in and around the scarred region, usually coming up from the sacrum. This is with or without hyaluronidase. And there have been mixed results with that. There have been some documented clinical improvement with that kind of treatment. Alternatively, you can perform an open lysis of adhesions, which is a tedious exercise, but you can get some improvement. However, without laying some type of barrier down or using some means of preventing adhesions, those nerve roots will likely just adhere again. So this really is like the myth of Sisyphus when it comes to adhesiolysis. Epidural steroids have been tried, as have spinal stimulators, as mentioned earlier. And of course, medications can be nice adjuncts, whether it's gabapentin, Lyrica, or your antidepressants. When you look at the techniques we have for managing epidural adhesions, it begins to make a lot of sense that maybe prevention is better than cure. And of course, there's been a lot of effort put into this. And you can generally put the means of prevention into two baskets. They're the barrier methods, which essentially are trying to keep a wall between where the scar is forming and the dural sac. And whether it's Dacron, gel foam, PTFE, or autologous fat, all of these are an attempt to keep the scar tissue away from the dura. These have met with mixed results. We've seen complications such as dural tears, scar dimpling from the autologous fat, seroma formation, and migration of the barriers. In particular, that would be one basket. The other basket would be chemical means of inhibiting scar formation, which seems a little more elegant. One option would be pirfenidone. Another option would be the macrolide antibiotics. There's some interesting papers on rapamycin inhibiting fibroblast proliferation. This is mediated by growth factors or TGF-beta. I have amniotic membrane in bold because one of the things that is a little bit that distinguishes amniotic membrane from the other barrier methods is that amnion is biologically active. And so not only is it going to provide a barrier between the dural sac and scar tissue, but it is going to modulate that environment. And it is going to change on the level of the chemokines how scars formed, how fibroblasts migrate. So you get the best of both worlds with amnion is one way to look at it. So what is amnion? Well, amnion is the innermost layer of the placenta. It's a biomaterial. This is as opposed to the chorion, which is the outer layer of the placental membrane. So you've got the amnion and the chorion, and there's some products such as NuShield from Organogenesis that preserve both the amnion and the chorion, as well as the spongy layer. And there are advantages to this in handling and the density of growth factors and cytokines that are preserved in the membrane. But again, this is bioactive material that also serves as a barrier. This material is going to continuously remodel the extracellular matrix. It has been used for 100 years and has a margin of safety. And it's going to affect the local environment by decreasing inflammation, vascularization. There's evidence that it even combats infection and, of course, is immune privilege. These anti-inflammatory products are suggested by decreased expression of interleukins as well as your TIMPs. It has also been noted that in the local environment, there's been sequestration of inflammatory cells via apoptosis of macrophages and monocytes. From a bird's eye view, what we are really doing with amniotic membrane when we are trying to address epidural adhesions is we're essentially down-regulating the inflammatory mechanisms that cause fibroblasts to migrate locally. Additionally, we're going to block fibroblast change to myofibroblasts. And in the process, we're going to inhibit angiogenesis, which is going to decrease the amount of granulation tissue and therefore the amount of scar. Now, a little bit about the history of amniotic membrane. It was first used in 1910 as a skin graft application. It was stored in saline and was typically used within 48 to 72 hours. We've come a long way since then. These days, we actually preserve amniotic membrane in two ways. It can be cryopreserved or dehydrated. And in the case of NewShield, this can sit on the shelf for 5 years or so. So we have much more flexibility with when and how it's used. Currently, it's been used in abdominal adhesions by general surgeons. It's been used by plastic surgeons for wound covering, for vaginal reconstruction, corneal disease, and of course, spine surgery. We were a little late to the party, but we got there. I'm always amazed at how I have friends and colleagues in other surgical specialties, how rarely we talk to one another. We all tend to live in our own technological bubbles, and one group of surgeons will figure something out and will be using it for years before it actually cross-pollinates into another group. And so, I mean, I think in some ways that's what happened with amnion and spine surgery. I feel like we got to the party a little bit late, but I think we are gradually beginning to adopt it more and more. And as a result of us being late, there are few studies that actually really are spine-centric studies that look at it. These are a couple of the most commonly cited. There was a study out of the European Spine Journal in 2009. It's a canine laminectomy model the investigators developed, and they were able to document decreased epidural fibrosis and adhesions. The same with the Journal of Korean Neurosurgery in 2011. They had a rat laminectomy model that documented decreased epidural fibrosis. In 2015, Dr. Subak out of Reston, Virginia, had a series of Tlift patients, 5 of whom he needed to take back to surgery. And he noted on re-exploration a markedly decreased amount of scarring in Camden's triangle. This mirrors exactly what I see when I need to take patients back. Typically what I see when I dock my tube in Camden's triangle for a revision is a superficial amount of scar several centimeters up from where I placed the amnion patch directly over the dural sac. As I approach the dural sac within a few centimeters, what I tend to find is a thin, adherent tissue that is very easily teased away from the dural sac, which lies right underneath. I have revised patients many, many times, and the difference between a patient with the amniotic membrane intact and placed versus one without one being placed is very, very striking. So I would echo what Dr. Subak found in his formal study. And lastly, Dr. Anderson out of Philadelphia designed a study in 2017 that looked at microdiscectomy patients. He had a group of 80 patients, which he randomized to getting a cryopreserved amniotic patch or no patch at all. And what he found at 24 months is that there was a statistically significant difference in ODI and SF12 scores in those patients who received the amniotic patch. He placed this patch directly over the annulus, which is something that I try to do in addition to laying it over the traversing nerve root and the thecal sac. However, it's also been described being placed directly on the dura or just directly on the nerve root. Ultimately, the goal is to prevent adhesions in the places where the adhesions are going to do the most harm, cause the most symptoms, or the space where you could eventually need to go back and revisit again. And last, are there indications in ACDF? My final case that I will describe might be a jump-off point for future studies as far as implementation in anterior cervical discectomies and fusions. So another case, this is a case, a very standard case that I will do. This is a Tlift case. This is a 65-year-old female, a grade 2 spondylolisthesis. She had all our favorite comorbidities, diabetes. She was a smoker. Her chief complaint was axial back pain with severe radicular symptoms. She had failed non-operative management to include epidural steroid injections and medications and physical therapy. I elected to perform an L4-5 MIS Tlift. I prescribed her a spine stimulator, anticipating that she would have some difficulty healing and fusing. I was right about that. The surgery was uncomplicated. She had an initial improvement. However, she declined after about the 6th week, which is a fairly common pattern we see in delayed unions or pseudoarthroses. Her back and leg pain continued to worsen. She had an X-ray sometime between the 6th and 12th week, which demonstrated a retropulsed cage, which you can see over on the right. Typically, when these cages retropulse, it implies that either there's a delayed union or that the cage was not secure. Given that I typically use an expandable cage, which interfaces very well with the end plates, they tend to be rather resistant to retropulsion without a pseudoarthrosis or something else abnormal. And in her case, her CT scan showed a robust osteolytic pseudoarthrosis. She had eaten through a lot of the bone locally in the region. This is a clear indication for a revision. The cage needs to be removed and a fusion needs to be stimulated. There are various techniques and ways of doing this. One technique that I tend to do, which I favor in the right situation, is I will perform a mini open technique. So I'll make a larger incision, come down directly over the hardware on the affected side where the cage is retropulsed, and I will remove the instrumentation. I will take the screws down over K-wires and leave the K-wires in place, and then I will drop a tube directly into Camden's triangle where the cage is typically retropulsed. I will go down, I will dissect through the scar tissue and identify, looking for the cage and of course avoiding the nerve root. This is made much, much easier if an amniotic patch has been placed. In her case, an amniotic patch was placed. And so, as I described earlier, I was able to drop the tube down, remove the superficial adipose and scar tissue. And as I got within a couple centimeters of the cage, the tissue around that area was an opaque white color, which I was able to basically tease away with a ball tip and pituitary. And underneath was the cage, as well, of course, coming through the annulotomy defect. And just medial to that was the traversing nerve root. I was able to attach something to the cage, hammer the cage out. Typically, this is beyond the scope of this talk, but I have a technique for stimulating fusion in there. Usually I'll use BMP. I'll try to get it very anterior against the ALL in the front, and I'll create another barrier between the BMP and the nerve root, as the BMP can be quite irritating to nerve root. However, I did this and she has done well since that time, and I believe she is about 6 months out from this procedure as of today. This is another case, very different, of a 32-year-old male with Bastrup's disease or Bastrup's syndrome. This is kissing spine disease. In these patients, for unknown reason, the spinous process is enlarged to a large degree, and they will rub against one another, causing chronic back pain. They can also oftentimes cause neurologic symptoms, usually radicular syndromes. In this particular case, this patient had chronic back pain. You'll notice a IVC filter On the x-ray, this was the result of a previous near fatal car crash that he'd been in 5 or 6 years prior. And so he presented, and after failing non-operative treatment, we took him for an open laminectomy, which is not something I typically do. I prefer to do everything through tubes, but the indication here was to perform a laminectomy to remove all that interdigitating bone that appeared to be the chief pain generator. Once performing the laminectomy, we had about 5 centimeters of exposed dura, which I covered with Amnion, usually a 2 by 2 centimeter patch, and I'll put those together. It took about 2 of those to cover the dural sac. I then close this patient in a careful layered fashion, and we'll usually leave a drain in for 2 days until I feel the drainage is well under 20 cc's in a shift. Importantly, in this patient, I also will usually put a gram of vancomycin powder. I will sometimes mix it with Stimulon, which is allows the vancomycin to sit in the wound and be viable a little bit longer. This patient had initial improvement in his back symptoms. However, after discharge from the hospital, he continued to have drainage from the wound, which was quite worrisome. We eventually worked him up for infection and were able to note a fluid collection deep to the lumbar fascia. He was taken back for an urgent irrigation debridement and culture. He grew out Morganella, which was sensitive to ciprofloxacin. Importantly, as the infectious disease doctors will tell you, how close the infection is and whether or not it is close to the dura is an important part of whether or not they, their treatment strategy, their duration and nature of their antibiotics that they prescribe. And so one of the most interesting features of what they were looking for from me was explore the dural sac, make sure that any purulence is not in direct contact with the dural sac. So of course I go down. This takes me right back into the epidural space where I had been for the laminectomy. And because of the amnion, I was very easily able to tease that away and take a very close look at the epidural region. Now, granted, this patient was only a few weeks out of surgery, so there wasn't a lot of time for dense scar to develop. However, this is yet another example of where this technology made my life easier than it would have been otherwise. And last, this is a example of a potential future use for amnion. This was a 57-year-old female with a dense cervical radiculopathy that had been refractory to epidurals, had been refractory to medication and physical therapy and traction. Interestingly, she had a history of severe endometriosis and had a lot of trouble with that in the past, as well as it had a previous abdominal surgery and developed thick intestinal adhesions that needed to be lysed. This patient I took for a C5 to C7 ACDF. She had immediate resolution of her radicular pain in the hospital, went home the same day, was talking to me after the surgery, had no problems eating, returned to see us at 2 weeks, had minimal dysphagia at that time, no hoarseness at all. She was a different person when she came in at 6 weeks. She had severe hoarseness, was having difficulty chewing solid food. It was quite dramatic. And spending time with her and having her work with us, a therapist, we were able to improve her dysphagia somewhat. But over time, this past medical history came out in more detail, and we began to put 2 and 2 together that this was likely scarring around her dural sac. The current plan is for her to continue with therapy, but if she continues to have problems with dysphagia, we may consider removing the plate once we've documented a fusion between C5 to C7. Once we remove the plate, I would try to lyse the adhesions in and around the esophagus. The thought is here, is there an indication, or is it worth exploring whether or not Amnion could potentially reduce symptoms in patients in whom you expect a robust scar? That would be a fairly easy study to design. So in summary, epidural adhesions are difficult to manage. Clearly, prevention is best. Amnion alone or Amnion chorion like NuShield has a lot of potential to help with epidural adhesions in spinal surgery. Amnion is a biologically active barrier, so it's really doing two things at once. It needs a better defined role in spinal surgery, but I think it is very promising and will have a wide range of applications. I want to open it up to questions, and I want to thank everyone for their attention, and thank Organogenesis and those who set up this day today. Thank you. Well, good afternoon. Thanks everybody for joining us today. Feel free to comment or ask any questions by typing them in on the chat function. I will take this moment while people are thinking of questions. There was a comment that I think really encapsulated what I was getting at the talk, which was essentially that epidural adhesions, lysing epidural adhesions manually is only going to result in more adhesions, which is precisely why we're in search of a need, we're in search of a way of preventing them. And also that fat grafts are probably the most well-studied and most common barrier method that's used out there. I've used fat grafts in the past, and one of the problems I think we encounter with fat grafts, having had to go back, unfortunately, and look at places where I've placed them, is that they do tend to migrate. Of course, it can be considered, an autograft type harvest tissue. So some people, particularly thin patients, may not have enough of it. One thing that I've been pleasantly surprised by is the handling characteristics of Amnion, especially when you get a product that combines both the Amnion and the chorion. It tends to adhere pretty well. And so I haven't had a lot of difficulty putting that on. Of course, chorion side goes down. It adheres very well to the nerve root and the dural sac. And when I've had to go back and re-explore these wounds, believe it or not, the Amnion is sitting exactly where I found it. It's kind of like you go through, I do a lot of work through tubes. And so I'm going through scar tissue of various degrees of maturity, depending on how late after the initial surgery I'm having to re-explore the area. And once I get close enough to where the dural sac was, everything just opens up, and there you usually will see a somewhat blanched membrane there that's very easily detachable from the dural sac. So it certainly makes things a little bit easier. And so I would certainly agree with everything stated in the comment. We all have failed backs as spine surgeons, and we estimate 30 to 40% of them are due to epidural adhesion. One other thing I wanted to chime in on that I didn't really hit much in the talk was you may be wondering, okay, well, I want to implement this in my practice. And I mean, I think this would be the same for non-spine applications as well. What is my workflow with this? Well, the first thing you've got to do is obviously you've got to get your hospital to buy in with you, and you've got to make it clear to them, that it is relatively well-established tech, but that you may need, especially in my case as a spine surgeon, had to make it clear to our purchasing, what the value of it was. So if you can get it in your hospital and you can get it on the shelf. The product I use by Organogenesis, NuShield, has a shelf life of 5 years. And so we've got them, we've got it, auto ordered now. And so we've always got a supply. I essentially have them pull it for every single case where I'm going to be in close proximity to the nerve roots. So that in particular, that's every laminectomy I do, every MIS Tlift that I do. I haven't really used it as I was talking about in ACDFs or anything like that. Haven't used it in my lateral access surgery either. But I'll have them pull it about 5 minutes before I'm about to close, which is normally when I have all the nerve roots explored and decompressed. I'll have them open it up. It comes in sterile packaging. And then I'll usually take a forceps, and then I'll detach my Frazier tip. And I will use those two instruments kind of to walk it down the tubular retractor, and then make sure that I've got the chorion side down, and then gently kind of nest that right over the nerve root. Normally I'll put it right over the axilla if I'm, looking at, S1 or something like that. And then I'll try to cover the dural sac as well. I referenced one paper by Anderson where they described their technique, where they actually saw an improvement in ODI scores in microdiscectomies. I think they had a cohort of 60 some patients, but he placed it over the annulotomy site, which is also described. I don't typically do that, but I tend to, makes more conceptual sense for me to put it right over the nerve root, but that's also been described. Again, the amniotic patches, they come in multiple sizes. So, depending on which company you're looking at, they've got about a 2x2 centimeter, 2x3 centimeter, a 4x4 centimeter. And I think the largest in most cases, like a 6x6 centimeter, and you can cut that up. And really, I think it depends on the application. I mean, I have kind of kept things simple for me. I standardize everything. So we use a 2x3. We don't overthink it, and that seems to fit most applications for what I'm doing. If anybody has any other questions. One other thing I think that's probably germane would be cost. Cost of Amnion, I think, runs our hospital, and our hospital, we're pretty tough negotiators, but I think we charge somewhere, our hospital pays somewhere between $600 and $800 per 2x3 centimeter patch. So, that may seem pricey, but if you're, in the world of spine surgery, that sadly may seem like somewhat of a bargain. A lot of our, for even haggled prices, a simple one-level fusion along with biologics, if you're using biologics, may run somewhere $7,000 to $8,000 for your materials. And so when you start looking at it from that perspective, I think if you've got something that may provide a little insurance for the inevitable revision you're going to have to do, and could potentially enhance your outcomes. Granted, and admittedly, more needs to be done to kind of document that. But certainly, you may want to consider it in your practice. Maybe worth at least, exploring. Okay, well, thank you for your attention, and please hold for the next presenter. Have a great afternoon.